All right, first slide. Next slide, please. All right, so all these 5 studies are pertaining to colorectal cancer. I'm going to present them in the order which I found most interesting. So first is the dynamic study. This is something that all of us have been waiting on for a long period of time. Does using circulating tumor DNA guided approach for stage 2 patients with colon cancer reduce the use of adjuvant chemotherapy without compromising the recurrence risk? Next slide. So this is how the study was done in Australia, 2-to-1 randomization. All patients had a stage 2 disease, were randomized, stratified by T3 or T4, type of participating center, whether it was a metro and regional, and 2 arms. The one in blue is the circulating tumor DNA guided management. And if the ctDNA was positive at week 4 or week 7, all those patients received adjuvant chemo. If the circulating tumor DNA was negative at week 4 and week 7, they were observed, 294 patients. And in the standard management, it was left to the discretion of the treating physicians as to who to treat with adjuvant chemotherapy, and 147 patients there. The study was done between August 2015 to August 2019 for 4 years. Next. These are the patients. So roughly the characteristics are very similar in both the arms. Slight differences. Left-sided tumors were more common in the ctDNA guided management arm. About a small number of patients had less than 12 lymph nodes, so good surgical staging. MMR deficient was equivalent on both sides, about 20%. And the high-risk group is defined by more than one high-risk feature. T4, poor tumor differentiation, less than 12 lymph nodes taken out at the time of surgery, lymphovascular invasion, tumor perforation, or obstruction, very similar to the NCCN guidelines. Next. This is how the treatment was done. I'd like you to concentrate on the table on the left-hand side. So circulating tumor DNA guided management, 15% of patients received chemotherapy as compared to 28% of patients receiving it in the standard management. So remember, this is a 2-to-1 randomization. So I'm going to focus on the percentage rather than the absolute number. The chemotherapy regimen received in the circulating tumor DNA guided management, 2/3 of them received oxaliplatin, because probably the investigators perceived this as being a high-risk population because they were ctDNA positive. 1/3 of them got single agent fluoropyrimidine. In the standard management, 90% of them received single agent fluoropyrimidine and 10% received oxaliplatin based doublet, because clearly the benefit of adding oxaliplatin is very high in stage 3 disease and lower in stage 2 disease. Time from surgery, there was a slight delay in the ctDNA because some of them started chemotherapy after the 7-week draw. And the treatment duration was similar across both arms, 24 weeks. By the time this study was designed, the 12 weeks versus 24 weeks was not out yet. It'll be interesting to see how this pans out in the shorter duration of chemotherapy that a lot of us are using in stage 2 and low risk stage 3 disease. Completing the treatment about equal. Next. So this is the recurrence-free survival. So the curves are virtually superimposable on each other. Even though in the circulating tumor DNA arm, only 15% of patients received adjuvant chemotherapy as compared to a much higher number in the standard arm, the recurrence-free survival was virtually ditto between the 2 arms, superimposable on top of each other. And on the right side, when you look at the forest plot, there was no difference between the subsets as the survival. So the circulating tumor DNA was predictive in all of the subsets. Next. This is looking within the circulating tumor DNA arm, ctDNA negative versus the ctDNA positive. Clearly, if your circulating tumor DNA is negative, the recurrence-free survival is much higher by about 6 to 10% as the curve keeps on going to the right. Next. Recurrence-free survival based on the ctDNA guided management and clinical risk. As you can see, in the low risk is better, intermediate is in the middle, and in the high risk, lower down. Next. So in summary, using circulating tumor DNA essentially reduced the number of people who received adjuvant chemotherapy in stage 2 patients from 28% to 15%. This did not compromise the recurrence-free survival at 2 years, was 93% versus 92.4%. So essentially identifying patients with this positive circulating tumor DNA after surgery may help benefit from, subselect those patients who will benefit from adjuvant chemotherapy. And identification of patients with a negative circulating tumor DNA also allows us to avoid adjuvant chemotherapy in this subset because the RFS is 92.5% in this subset of patients. Next. So this was the final conclusion. So ctDNA can be used to identify patients with stage 2 colon cancer who will benefit from adjuvant chemotherapy, as well as identifying patients that do not require chemotherapy while maintaining good outcomes. Next. The second trial I want to present is a paradigm trial. Next. So the paradigm trial asked a question in the metastatic setting: panitumumab or bevacizumab in combination with modified FOLFOX6 provide benefit for patients with unresectable colon cancer without the RAS mutation in the frontline setting. Next. So this is how the study was done. It was stratified by institution, age, and whether they had liver metastasis or not. The two arms were modified FOLFOX6 in all patients. Half the patients got panitumumab, the other half got bevacizumab. Primary endpoint was overall survival in the left-sided population and overall survival in the overall population. Next. And this is the number of patients baseline characteristics. Left-sided patients, and on the left side, overall population is on the right side. Age is very similar. About a third of them were women, 2/3 are men. Primary tumor location of all the patients, about 78% of patients were left-sided, about 20% of the patients were right-sided. Metastatic sites, as you can imagine, liver as the only site of mets was about 30%. Liver had mets in about 70% of the patients. Next. So this is the overall survival in the left-sided population. Panitumumab is the arm in blue and bevacizumab is the arm in green. As you can see, the number of events and stratified hazard ratio for death, hazard ratio of 0.82, which was statistically significant with a p-value of 0.03 in favor of panitumumab. And we looked at the overall survival analysis. The forest plot is on the left side. Benefit seems to be across the board. Some of them are crossing the zero barrier line, but again, very small number of patients in those subsets. Next. This is the overall survival in the overall population. Again, stratified hazard ratio for death of hazard ratio of 0.84, p-value very similar, 0.03. Again, the subset analysis, as you can see, very similar to the previous one that I showed you in the left side population. Now, granted, in this overall population, 80% of these patients were left-sided and only 20% of these patients were right-sided colon cancer. Next. This is the exploratory overall survival in the right-sided population, because as you know, there are prior studies which have shown that EGFR inhibitors may not be effective. So looking at this subset, 71 versus 85%, and the curves do cross each other. There is no benefit between the two arms that we can discern from this analysis. Next. This is the PFS in the left-sided population. There was no significant benefit in PFS, hazard ratio of 0.98, statistically equivalent. PFS in the overall population also, there was no benefit between the two with a hazard ratio of 1.01. Next. These are the response rates. So as you can see in the left side population, there was an improvement in response rate with panitumumab, 68 versus 80%. Disease control rate was very similar. R0 resection was 18% in panitumumab as compared to 11.6 in the bevacizumab arm. Next. This is the depth of response, and the watershed curves are in the bottom. As you can see, slightly favoring panitumumab and the amount of tumor shrinkage that was achieved. Next. Coming to the safety, as you can expect with the adverse events, Most of the side effects with panitumumab are related to the gastrointestinal tract, skin, side effects, electrolyte abnormalities with hypomagnesemia, which can be troublesome, and some amount of hypersensitivity reactions to the drug. Whereas with the bevacizumab, most of the complications would be related to myelosuppression, vascular events, and such. Next. So in summary, it showed that panitumumab in combination with FOLFOX6 compared to bevacizumab provides significant improvement in overall survival in left-sided and overall population in the frontline setting. PFS was comparable for both arms. R0 resection and response rates were higher in the panitumumab arms, and no new safety concerns in either arm. So this does give you a valid option for frontline treatment. Next. Next slide. Next, I'm going to show you the triplet trial next, which is going to make it more confusing. So here the question was, does triplet chemotherapy, FOLFOXIRI versus doublet chemotherapy with either FOLFOX, FOLFIRI with panitumumab provide benefit to patients with unresectable metastatic colorectal cancer in the frontline setting? Next. This is the study schema. The one in the red is the triplet plus panitumumab for up to 12 cycles. And the one in blue is modified FOLFOX6 plus panitumumab for up to 12 cycles. Primary endpoint of this trial was overall response rate. Secondary endpoints, depth of response, early tumor shrinkage, R0 resection rate, PFS, and OS. Next. These are the baseline characteristics, fairly similar between both arms. Median age of about 59. 2/3 of the patients were male. Prior adjuvant chemotherapy was very similar. Liver-only disease of about 40%. Left-sided cancers of about 88% in this population. So they heavily used left-sided patients and also patients with, all of them had to be obviously the KRAS wild type. Next is the MMR proficient and deficient is small number of patients with MMR deficient. Next. These are the response rates. So triplet versus doublet. The triplet is on the left side in the table. The doublet is on the right side. Was 73% versus 76%. PR, CR, very similar. Median depth of response, very similar of 48 versus 47. R0 resection of 25 versus 29. And when you look at the subgroup analysis, small changes. In the right side colon cancer, there was a slightly higher benefit in using a triplet. Next. This is the PFS. As you can see, the median PFS is very similar between the two arms, 12.7 versus 12.3. Hazard ratio is very similar, 0.88. P-value was not statistically significant of 0.277. And when you look at the forest plot on the right, no specific subset where you can say there was benefit from one versus the other. Next. These are the safety data. As you can imagine, when you're comparing a triplet to a doublet, you'll see more side effects in the triplet. And that's what we saw. Neutropenia risk increased from 20% to 32%. The diarrhea increased from 7% to 23%, mainly because the irinotecan. Next. So in summary, triplet chemotherapy in combination with panitumumab did not provide benefit compared to doublet chemotherapy in combination with panitumumab in patients with metastatic colorectal cancer without the RAS or BRAF mutations. Overall survival results are still mature, and obviously higher rates of grade 3 and 4 side effects in the triplet arm. Next. So essentially, intensification of chemotherapy in combination with panitumumab in the front line does not provide and should not be recommended to patients with RAS and BRAF wild type patients based on this trial. Next. The next study I'm going to present is the Cairo study. Next. So this study asked another question. Does triplet chemotherapy, FOLFOXIRI versus doublet chemotherapy plus bevacizumab provide benefit in patients with unresectable colorectal cancer and right-sided patients in this study? Next. So they used obviously two things to enrich the study. Number one, so they essentially wanted to study patients who would not get benefit from EGFR antibodies. So they use patients with right-sided primary and also patients with the RAS or BRAF mutation. And they divided them into two arms, doublet plus bevacizumab as compared to triplet plus bevacizumab, and then followed by maintenance 5-FU plus bevacizumab till progression of disease. Next. The baseline characteristics very similar, median age of about 60, 2/3 of them were male, right-sided primary of about 40% of the patients, about 80% of the patients had a RAS mutation, 7 to 8% had a BRAF mutation. Median number of liver metastasis was about 12, so fairly heavy disease burden. Preference from oxaliplatin in the doublet arm was in 93% of the physicians. Next. This is the PFS looking at doublet plus bevacizumab as compared to the triplet plus bevacizumab. Quite clearly, as you can see, the triplet does come out ahead of the doublet in the graph with a clear splitting of the curve. The median PFS for the doublet was 9 months as compared to 10.6 months, hazard ratio of 0.77. So about a 23% improvement in PFS by with a triplet as compared to a doublet. P-value of 0.03. Overall response rate, as you can see, went up from 33% to 53%, again statistically highly significant at 0.001. There was no significant interaction between a baseline unresectability or a mutation status, and the overall survival data is still not mature. Next. Safety-wise, as you can assume, when you add it, when you have a triplet versus doublet, very similar. There's a significant increase in myelosuppression. Neutropenia went up from 12.9 to 38%. Diarrhea went up from 3.4 to 19%. Toxic deaths, there were 2 toxic deaths in the triplet combination. So you got to be careful in who you deliver and select these patients. Next. So the next one was the resection. So if you look at the resection, doublet versus triplet, resection went up from 46% to 57%. The p-value was not statistically significant of 0.08. Median number of induction cycles was about similar in both arms, about 6 or 7. Next. And these are the outcomes. If you had an R1 resection with or without ablation, on the left side is the doublet with bevacizumab. And what you're seeing is the comparison between no resection versus resection. The resection is the arm in blue, and the no resection is the arm in black. So essentially, as you can see, if you had a resection, patients did better, which is fairly easy to guess. So the PFS improved from 7 months to 11.9 months. And in the triplet arm, again, it improved from 9 months to 12.7 months. Next. So what did we learn from this study? So for patients with initially unresectable colorectal liver mets and right-sided tumors, triplet therapy versus doublet chemotherapy significantly improves PFS, overall response rate, and R0, R1 resection with or without ablation. The overall survival data is still not mature in this trial. The triplet does have increased toxicity, so you have to carefully select your patients for this trial. The utilization of a liver expert panel allows for the selection of an increased number of patients who are eligible for local treatment with curative intent. Next. Next. So the last study I'm going to present is something that you probably have been asked about 20 times when you came back from the ASCO meeting and had to explain to your patients, you really don't qualify for this. And yes, this is something I can offer with a different drug in my own office. This is a question you've probably been asked at least 20 times by your patients. I have been. So this is a study which got a lot of press. So it's looking at PD-1 blockade in the MMR deficient patients in rectal cancer. So the question which was being asked is, does a checkpoint inhibitor provide benefit to patients with MMR deficiency and locally advanced rectal cancer? Next. So this was a non-randomized open label phase 2 study. Patients had to have MMR deficiency. They had to have stage 2 or stage 3 rectal cancer, no evidence of metastatic disease, good performance status patients, and a small number of patients, about 30 patients. So I think more patients in your practice have asked you about this question than actually the number of patients who have participated in the trial. So this used a novel drug, dostarlimab, an anti-PD-1 monoclonal antibody given 500 milligrams every 3 weeks for 6 months. So total of 9 cycles. At the completion of 6 months, patients had a full evaluation, which included rectal MRI, PET CT, as well as an endoscopic exam. And they were divided into two subsets. Patients who had a clinical complete response. So if they had a clinical complete response, no further treatment was done. No radiation, no chemotherapy, no surgery, non-operative management, and they were followed up every 4 months with no further therapy. And patients who had residual disease went on to receive chemo-RT, and then they were stratified again into 2 groups. If they were to have a complete clinical response, they were watched. And if they did have residual disease at the end of chemoradiation, they were planned to take on to surgery. It's a fascinating study design. And when you see the data, you will see why it excited so many people and got so much press after the conference. Next. So the baseline characteristics, a younger group of patients, median age of 54, about 2/3 women, 1/3 male, 60% Caucasian, 17% African Americans, 17% Asians, and 6% Hispanics, 1 patient. A tumor staging, T1 or 2, 20% of the patients, T3 and 4, 78%. Significant number of patients with lymph node positive disease, 94%, so about 17 out of the 18 patients. Germline mutation status, about 60% of them had a germline mutation. BRAF wild type, all of them are BRAF wild type. And they had a significantly high tumor mutational burden of 67. Next. So these are the individual responses. The 14 patients that are listed is on the left side. And as you can see, the overall response is on the right side. All of them had a complete response. Next. This is the duration of response. So some of them have a very short duration of follow-up. So as you can see, all of them are achieving a durable remission. Next. So in summary of the accessible patients, 100% clinical complete response was achieved in 14 patients. No patients have required chemotherapy, radiation, or surgery. Quite fascinating. No disease recurrence observed during the follow-up period. No grade 3 or 4 adverse events were observed. Next. So dostarlimab in the frontline setting provides a potential curative option for patients with MMR deficiency without the need for chemotherapy, radiation, or surgery. As I mentioned, an extremely small study, so more to come on this. But we have all seen this and we've witnessed this in stage 4 disease, where we have patients on either Keytruda or Opdivo with colon cancer in complete remission when they have underlying MMR deficiency or microsatellite instability. Next.